Rahman Rahim. Our lecture today is about chronic hepatitis. This is our agenda. The liver is the largest internal organ with double blood supply, 1.5 liters of blood flow through it every minute. This is the classical anatomy of the liver with the right lobe and left lobe. This is the most recent segmental anatomy of the liver with 8 segments, each segment with its separate blood supply and venous drainage, bile duct, and portal vein branch. The liver is a chemical factory. Filtration of blood from the digestive tract before passing to the stomach circulation, detoxification of chemicals, metabolization of drugs, bile secretion, protein synthesis, and lastly, the healthy liver can regenerate itself. What's hepatitis? It is inflammation of the liver, may have infectious and non-infectious causes. The non-infectious causes include autoimmune reaction, allergic, drugs, obesity, heavy drinking. The most common causes of viral hepatitis are the 5 hepatotropic viruses A, B, C, D, E. In addition to the hepatitis viruses, other viruses can also cause liver inflammation, as herpes simplex, cytomegalo virus, Epstein-Barr virus, and yellow fever virus. This is the hepatotropic viruses. When I talk about hepatitis B and C, these are the 2 examples of chronic hepatitis. I want to highlight 2 points. The genome of hepatitis B is DNA, while the genome of hepatitis C is RNA. Hepatitis B occasionally severe, with the chronicity in the adults about 10%, in contrast to HCV, with the chronicity more than 70%. Chronic hepatitis is diagnosed when there is persistence of hepatitis markers more than 6 months. Hepatitis B virus has 3 antigen antibody systems: hepatitis B surface antigen and antibody, hepatitis B core antigen and antibody, hepatitis B envelope antigen and antibody, hepatitis B S, hepatitis B core, and hepatitis B E. Hepatitis B S antigen is the marker of infectivity. It is present in secretion, saliva, urine, semen, tears, sweat, and breast milk. Hepatitis B S antibody is a protective antibody. It can persist for many years and appears after hepatitis B S antigen disappearance. Hepatitis B core antigen is the marker of replication. Hepatitis B core antibody IgM is the marker of acute infection, while hepatitis B core antibody IgG is the marker of past infection. Hepatitis B virus DNA is a direct indicator of hepatitis B infection. It can integrate itself into the genome of hepatocyte. So, hepatitis B virus may cause hepatocellular carcinoma early without passing through cirrhosis. Hepatitis C virus is the most common indication of liver transplantation all over the world. Diagnosis starts with hepatitis C virus antibody, which is the marker of infectivity, while HCV RNA is the direct evidence of infectivity, it may be detected from blood or liver tissue. The modes of transmission include blood transmission, body fluids, high-risk sexual activity, mother to infant in hepatitis B, shared personal items, occupational exposure, or intravenous drug user. These are the accused modes of transmission. Mostly the personnel of hemodialysis, not the machine, which may transmit infection. Personal items, acupuncture, and contaminated syringe. Clinical manifestations of chronic hepatitis: when there is persistence of markers more than 6 months, persistent or intermittent fatigue, weakness, anorexia, muscle and joint pain, right hypochondrial pain, and may be asymptomatic. If progressive to liver cirrhosis, there may be hepatic decompensation, jaundice, variceal bleeding, ascites, lower limb edema, hepatic encephalopathy, coma. Signs include hepatomegaly, splenomegaly, muscle wasting, palmar erythema, spider angiomas or spider nevi, gynecomastia, abdominal collateral veins or what's called caput medosa. This is the palmar erythema, where the redness in the thenar, hypothenar, heads of metacarpals and terminal phalanges with central pallor. Spider angioma or spider nevus with feeding arteriole in the center and capillaries. Jaundice, ascites, caput medosa, dilated veins with blood flow away from the umbilicus. There are some extrahepatic manifestations of HCV as cryoglobulinemia, idiopathic thrombocytopenic purpura (ITP), lichen planus, necrotizing cutaneous vasculitis, and non-Hodgkin lymphoma. This is the natural history of hepatitis C virus infection. About 15% will resolve after acute phase, while 85% pass to chronic stage. 20% of them pass to cirrhosis. About 6% per year pass to end-stage liver disease. 4% per year develop hepatocellular carcinoma, with the end result either death or transplant. But this trip or this journey take about 20 to 30 years for progression from acute phase to HCC or end-stage liver disease. The role of the good physician to cut it early. If the patient is presented to physician, to hepatologist with acute phase, he must treat before passing to chronic. When the hepatologist diagnose the patient with chronic, he must treat before passing to cirrhosis. When you meet a patient with cirrhosis, you must treat him to delay the progression to end-stage liver disease and early detect hepatocellular carcinoma and refer your patient for liver transplant as early as you can. The laboratory investigations include alanine aminotransferase, aspartate aminotransferase, which are markers of degeneration or necrosis of hepatocytes, alkaline phosphatase, and gamma glutamyl transpeptidase gamma GT, which are markers of cholestasis, total and direct serum bilirubin, serum albumin and prothrombin time and INR. Albumin and INR are the markers of synthetic function of the liver. Radiologic investigation include abdominal ultrasonography, which is simple bedside diagnosis, abdominal CT scan, and abdominal magnetic resonance imaging MRI. This is CT picture, CT film. Complications: liver cirrhosis, portal hypertension, liver cell failure, hepatocellular carcinoma. Is hepatitis B preventable? Yes. Control of source of infection, cut off the route of transmission, protection of susceptible population, active immunization and passive immunization. The role of the hepatologist when he treats a patient with chronic hepatitis B, he must do prevention for the relatives. Prevention of hepatitis C, till now no available vaccine, but prevention through avoidance of all modes of transmission as you can. Treatment of chronic hepatitis B. In the past, pegylated interferon alpha, but now there are 4 oral agents: lamivudine, adifovir, entecavir, tenofovir. When I pass from lamivudine to tenofovir, the resistance become less, the efficacy becomes higher. Treatment of chronic HCV. In the past, pegylated interferon alpha, nowadays plus ribavirin. Nowadays, direct acting antiviral agents plus or minus ribavirin. Direct acting antiviral agents, site of action, non-structural viral proteins. Non-structural viral proteins are the site of action of direct acting antivirals. Examples: sofosbuvir, cimiprevir, daclatasvir, lidibasvir, ombitasvir, baritabravir, ritonavir. This is sofosbuvir, cimiprevir, daclatasvir, lidibasvir with sofosbuvir, ombitasvir, baritabravir, and ritonavir. This is a site of action. There are 7 non-structural proteins with a list of direct acting antiviral which act on each non-structural protein. For example, sofosbuvir on non-structural 5B, daclatasvir on non-structural 5A, tilaprevir, cimiprevir, pociprevir on non-structural 3 and non-structural 4A. Lastly, when direct acting antiviral are used in the proper situation, it will be relatively safe, well tolerated, with minimal side effects. Thank you.